Good morning. Welcome to the second episode of the series of the EAMC 3.0 feedback series. Welcome. It's lovely to have you all connect with us, and also those that would watch this back. Thank you for watching this. And today we've got an interesting panel. We've got interesting people here, and I'll just start with some introductions. So my name is Tolu Olaniyan, and I'm the CEO of Pretola Global Health and Consulting.
Hi everybody, my name is Torie Robinson. I'm CEO of Epilepsy Sparks and Epilepsy Sparks Insights. I'm podcast host for that, released today.
Eve.
Good afternoon, I'm Evelyn Chibwe. I'm a nurse, registered nurse by profession, and I'm a technical assistant working with the Ministry of Health in the NCD department. Thank you.
Samuel.
My name is Samuel Chigamba, and I'm the Executive Director of Epilepsy Warriors Foundation based in Blantyre, Malawi.
Kumbukani.
Yeah, good afternoon, everyone. I'm Kumbukani Phiri. So professionally, I'm a clinician, clinical officer working under Chigamba District Hospital, that's Malawi.
Thank you for joining in. So it's still morning here in the UK, but it's afternoon where you are, and that's the advantage of being able to connect and being able to network with people across the world. So thank you for joining in today. And really, the reason why we're here is to get some feedback from our participants on the EAMC 3.0 series that we had. So the Epilepsy Assessment and Management course, we had the third edition this year, January to March this year, and we had nearly 300 clinicians from 36 countries attend. And this year, we had over 30 clinicians from Malawi. The first time we had the EAMC, we had just one clinician from Malawi.
Whoa.
So this year, we had over 30 clinicians, and which Evelyn, Eve, and Kumbukani were part of that cohort. So really today we would like to get some feedback from them. We'd like to hear some of the things they learned on the EAMC and how they're using the learnings, the skills and the knowledge they've gained on the training to improve care in their country.
And I would just want to add to that as well. I can totally relate from the patient perspective as well as professional perspective, because I'm actually a patient myself as well. And so knowing that we have, was it 30 or over 30 people on the course from Malawi alone is really exciting and heartwarming at the same time. I want to start with you, Eve. Could you please tell us, if before the EAMC 3.0 course, if you'd done any sort of similar training regarding the epilepsies, and what did you get from this training?
Actually, the issue about epilepsy, I learned it in class when I was doing my bachelor's or degree of nursing. That was 2006, somewhere there. So I registered for the course, and along the way, I learned a lot in the course, and most thing that came out of it and that stand out, which we rarely talk about, it's on the transitioning phase, on how do we transition pediatric patients to adult clinics. Kumbukani can agree with me that really there is some challenges on how we manage the difference between adult clinicians and pediatric clinicians. And so when this lecture came in about, it was very interesting on how we can do best. And it's something that I'm looking forward to develop transition guidelines on how best we can do this at a policy level and how we can manage the patients comprehensively. And the other thing that really stood up is the way we handle these clients. It's not mostly patient-centered or family-centered care. It's just okay, the patient comes in, I'm going to treat him as the way I treated the previous patient. So emphasizing on the importance of family-centered care is very vital, and I saw it very necessary when it comes to managing patients with epilepsy. There are moments whereby a patient comes in with different seizures. Every time when he comes to the clinic, they say the frequency of seizures have increased, but we never go back and assess how the family is doing. Is the patient being monitored on how he's taking medication? What are some of the other stresses that may precipitate seizures which need to be controlled before even increasing the dosage of the drugs. So it's something that I looked up to, interested in it, and it was something that really stood out. And I think being a nurse and being an educator, I think is something that I will emphasize. I know we've had different trainings with Kumbukani when we're talking about epilepsy and all that. So I think we'll start there and pairing up with Kumbukani, going to Shikwawa districts and even covering a lot of districts because we move around. We have NCD clinics. So it's something that I'm looking forward to, and making sure that nurses are trained in combination with clinicians, because it's a multidisciplinary care. So with the nurses being involved and the whole team who attend to these patients, I think it would be something that I'm looking forward to, and just emphasizing on the importance and raising awareness with Samuel in most of the epilepsy things that are cutting across Malawi.
Oh my goodness, that's lovely feedback. Thank you so much, Eve. It sounds like it was really interesting to you as well as a clinician, and how you just said that, how you can actually implement what you've learned is, yeah, that sounds like wonderful. And it also sounds like you encourage perhaps to share what you've learned with other clinicians in your part Malawi, which is brilliant. So thank you. And also Kumbukani, as you were mentioned, and as you're a fellow clinician, I don't know if you two work together, or what were your takings from the training?
Yeah, so just like if I also I did my initial actually training on epilepsy when I was doing my bachelor's in mental health. So it was just a basic knowledge. I know this was it was so inclusive ideally. So we covered a lot. We covered the genetics part, how genetics is contributing about over 50% of all epilepsies. So just like if I said here in Malawi, I think epilepsy, people have very little knowledge about epilepsy. So you'd see they'll have their children conversing at their homes. They don't believe in actually taking them to the hospital, which at the point they're coming to the hospital, they already developed some neuropsychiatric complications from untreated epilepsy. Yeah, so it's like this training has really helped us, that we actually look forward to, actually, as Eve has put it, we need to do more trainings, actually do a lot of sensitization so that people have enough information about epilepsy. They really need to know that epilepsy is treatable, as we've learned in this course. So it's up to 70% we can control the seizures, just to make sure our patients they improve their quality of life as well. So moving forward, I think according to this training, we as clinicians will try actually to roll before more activities at district level, so that we treat as more nurses as possible. The other interesting thing that I've learned from this training, so from our setting, I think we take epilepsy as a mental health disorder, not as a general medical condition. So because of that, you see every epileptic patient, they are referred to either psychiatric nurses or psychiatric clinicians, which are very, they are very few in our setting. So you get the whole facility has 2 nurses, maybe 1 clinician. Then it's not easy for a single clinician to see all the patients. So once we've managed to train a lot of nurses, clinicians on epilepsy and their management, we really look forward to improve the welfare and how epileptic patients live on daily basis.
Thank you so much for your input there. Something special about the EAMC training is that there's a special section devoted to hearing from patients and families, which is not normally included to such a degree in most epilepsy training courses. And I wonder how hearing and listening to things from the patient and family perspective, how you think that may have contributed to your understanding of the epilepsies and how it might change your outlook.
Torie, I think, as I stated earlier, understanding or hearing from the clients or the guardians themselves, or the perspective or management of epilepsy would be really good, because it also direct on the type of care that they receive, and also understanding on how the community itself understand the condition, on how the challenges that they are facing. I'll say in an example whereby students or kids go to school. So when you understand their perspective itself, like maybe they are being discriminated about the condition, they've been sent back to school because they had a seizure, something like that. It will help us go even beyond the healthcare system. Now you look at the education system. How are these people being managed? So it all cuts across different sectors with epilepsy, because we're looking at the community. Are these clients being involved in different activities that the community are involved? The issues whereby sometimes these clients, they don't come to the clinics because they are afraid of the community. It is seen as if epilepsy, okay, fine, you've been bewitched. As such, the clients don't come to the clinics, or they're just isolated in their homes. When you go to the community, you'll be amazed or you'll be shocked. Like some of these kids, maybe Samuel can also testify on how they are managed at home. They are just secluded in an area because they say, you give us, when we touch your urine, when we touch your saliva, you breathe the air into us, then we have epilepsy. So just hearing them out on the challenges that they are facing, the drug adherence and all that, I think it will enable us even to better understand our patients and manage them effectively, and maybe raise our awareness and teach the community that this is just like any other condition, that if managed well, these people are productive in the society. And just maybe understanding some of or taking in action with some of the things that can help us or promote epilepsy awareness.
Do you know what you've reminded me? I'll let Tolu step in a second and you can speak to Samuel. But I actually had a chap, I can't remember from which African country it was, and it was a year or two ago, but I will never forget it. He messaged me and asked if he was going to marry this lady who had epilepsy, and asked me if he could catch it through kissing her. You know, so, and this was, he didn't have intellectual disability or anything like that. It was an honest question. He was embarrassed to ask me, but of course I did say, no, it's not contagious, none of that. And he was very relieved, and they got married and da-di-da. But it's, yeah, so I think it's just so important, and also very comforting to know that both you, Eve, and Kumbukani, that you've learned so much from this, and you can help educate individuals, families, and communities.
Sorry, actually, it just reminded me of something that relates to like the side effects of the drug, especially in the reproductive age groups. So it also said, okay, some medications are not supposed to give them in the reproductive age groups because it also affects them or the teratogenicity in the kids. So I think that point as well, Kumbukani should take it and emphasize on what types of drugs that need to be avoided in this type of reproductive age group. And maybe we should be able to make more noise and say what type of drugs are being given, and maybe this source constraint that we have on medication. However, we just have to make noise in this. Yeah, thanks.
Yeah. Thank you, Eve. Very, very important points, we've raised just talking. And really about the bit I want to talk about is about when people have got like myths, how we actually address myths, like the way Torie said, someone contacted her to say, oh, can I catch, epilepsy by kissing if I get married to this woman? But we don't just say, oh, it's rubbish. We actually address it because people are genuinely concerned. Parents want to support their children, but because of what they've heard about this epilepsy, because of things that have been passed along from one culture to the other, from one generation to the other, they're stuck thinking it's true. But we do need to address it by actually supporting them to understand actually it's not true, and this is why it's not true. that way they can now understand, okay, now I can actually hold my child. Like, actually, I can support my child. Actually, I don't need to isolate my child. But we can only do that by meeting them where they are, by actually addressing their concerns and not just ignoring it. So it's so important that we do that. So there's that aspect of advocacy, there's that aspect of community awareness, there's that aspect of dispelling myths and cultural misconceptions around epilepsy, because those are the key aspects that actually make stigma thrive in our communities, and we need to deal with it. And another bit that Eve said was about the transition bit as well. And that topic was taken by Kim Molly. And you also mentioned about maternal care, medication during pregnancy and potential women that could get pregnant was taken by Kim Molly. Those topics were so good that a lot of people had a lot of questions about those topics, especially around sodium valproate, because those are that's one of the most common medication available in our countries. It doesn't mean that it's a very good drug, it's a very effective drug, but then can impact some people, especially those with women of childbearing age and also during pregnancy as well. So it's being aware of it and how to manage that process better, and also being able to choose. So being aware of this medication would give us that knowledge that we need to actually go to the people in charge of getting us medication, Board of Health and health boards and all that, to actually say we need more medication, we need more a variety of drugs, really. And one of the things we did on the EAMC was to focus on common drugs available in low resource countries. And because there's so many new drugs now, in this part of the world, in the UK, in the US, and other Western developed countries, but are not necessarily available in low resource countries. So there's no point that we do training on those drugs that you don't have. So if you remember, before you did the EAMC, we sent you a pre-course, a questionnaire to actually complete with give us details of medication you have, so that we could tailor the training towards your needs about the medication you have. And that was really great, really. And we had a lot of feedback about that. I don't know, Kumbukani, if that really helped to just talk about the medication you have. Of course, we mentioned a few that you don't have, but actually equip you on knowledge you need about the medication you have in your country. How did you find that?
That was really vital. It really helped us. So the problem with us this side, it's we don't even the common drugs, the common phenobarbital. We find we have a lot of regular stockouts of those drugs. But then having that questionnaire of just to know what drugs are available for us, that really helped us. So we really appreciated the new drugs that are there. So we have a lot of drugs, but then the common ones that are always available are just a few. Yeah, so in low resources countries like Malawi, we usually have the basic phenobarbital. You see sodium at times, not all the times. But then I think that really helped us in during the course as well. And at least we should have a variety of, a choice of among many drugs. Yeah.
Yeah, thank you. Samuel, I want to come to Samuel Chigamba.
Yeah.
So you are the founder of Epilepsy Warriors Foundation. You're not a clinician, but you are actually an individual with epilepsy yourself that's founded an organization in Malawi.
Yeah.
But then you contacted us. You contacted us at Pretola Global Health and said you wanted to coordinate making sure nurses in Malawi attended this training. Tell us why and how you did that.
Firstly, I would like to say that this has been one of the most beautiful, courses that I've coordinated. One of the most beautiful projects that I've coordinated. So, as a person with epilepsy and a founder and executive director of an organization for persons with epilepsy, we've had the idea of training nurses. If you can remember, last year we trained one nurse, Mary Kumanda. The idea was that she should also train other nurses. So coming around this year, we thought that it might be wise that also we coordinate, because we knew that most nurses might have some challenges in with the internet, or even accessing their gadgets. So we thought it might be wise to coordinate this project. We wanted it to be successful. Yeah, that's why we approached you.
It was not just coordination. There was quite a lot of work that had to do with it.
Yeah.
And this is one aspect that I really wanted us to talk about today, about we're actually working towards empowering and educating clinicians in parts of our countries that they wouldn't necessarily have access to this training. And that's the beauty of the EAMC, that actually you can connect wherever you are at and learn from some of the best clinicians across the world. But then, being practical, there's some practical issues that come with that. So there were issues around, I know in some countries, well, in my country that I'm originally from, Nigeria, there could be issues around power outage. There could be issues around data, access to Wi-Fi, which we take for granted here. It's there everywhere you go to. But actually, Samuel and his team, Epilepsy Warriors Foundation, you ensured that the clinicians, you raised funds in your local area and ensured that they had access to funds to actually get the data they needed to attend the training.
That's true. Actually, I would like to thank our friends and supporters, both locally and international. Because and also the Cancer Survivors Quest, an NGO based in Blantyre, Malawi. We used their main broadcast list to send our messages. Actually, most of the support that we received came from their members. So yeah, it's been a very good experience. And yeah,
you did that. So thank you. And then you also taught them how to use Zoom, because there's some knew how to use the gadgets well, fair enough, but some needed extra support on how to use Zoom, how to access the recordings on the platform, and a whole lot of technical support that you gave. You liaised with our team, and we also provided that you did some recordings. And this is just to ensure that this over 30 clinicians, 30 registered through you. There were more than 30 that registered in Malawi. But they had the support that they needed to be able to attend the training for the 3 months. And when I was thinking about this, really, what came to my mind was, it takes a village. It takes a village to raise a child. It takes a village to address the needs of people with epilepsy. It takes more than just the clinicians. It takes working together with advocacy services, because we put together the training, but you actually did the groundwork in your country.
It's also, it takes together with working with, I would say, like-minded individuals, because if you can see, we also work with Cancer Survivors Quest, an NGO which is doing something to do with cancer, but they supported us. So I think it takes a lot. It
takes a lot. Thank you. And Kumbukani, I wanted to go to you as well on this point. So before we joined on live, we were having a discussion about some of the key learnings, key topics that we picked up, that we learned on the EAMC, and you actually spoke a lot about week 1, the first week, and the second topic taken by Professor Lisk on epilepsy in itself, epilepsy overview. We spoke about causes of epilepsy and the prevalence of it. So you said you were not even aware of the numbers, that you were shocked of the numbers, and also the preventable aspects of it. Maternal care. Do you want to talk about that?
As we're discussing, as one of the things that we would like to actually share with our community when you go back on community awareness, we should provide the information that we got from this training, EAMC training. So we learned that actually epilepsy is treatable. So the seizures can be controlled up to 70% of the seizures. So, and that's achievable having all the resources, including the drugs. So we also discussed in this training that there is almost a 70% treatment gap in actually treating epilepsy. So which is too much. So the contributing factors should be, as Evelyn said, in our setting, people believe in witchcraft a lot. They would think if their child is having epilepsy, it's because they've been bewitched. So they would not want to seek care. Or should it be that we don't have necessary skills in diagnosing and treating the same? So we also discussed that epilepsy can be prevented up to 25%. So this is due to some preventable causes that we discussed that I'll actually share as I go along. So 25% preventable. So those causes that we can, as human beings, we contribute in actually, eventually they end up actually somebody developing epilepsy. So up to 25%. So we also discussed that education like this one, EAMC, will actually help in proper diagnosis and the management of epileptic patients. So as we go back to our facilities, we'll actually to have an impact on the knowledge that we've gained from this training on how we're taking care of our patients. So on epidemiology, we discussed that actually epilepsy affects close to 50 million individuals, so globally. So that's a very huge number. So epilepsy has to be included as one of the conditions affecting a lot of people as well, globally. So has an incidence of about 50 in every 100,000 individuals globally, with a prevalence of 0.5 to 1%. So which is a significant number as well. So we learned that generally there is a delay in seeking care. So, uncontrolled seizures will actually will bring a lot of negativities, a lot of, effects to an individual. So the quality of life, they're unable to perform their daily duties, even affecting the siblings and the family. Mm-hmm. So if they're having somebody who is conversing 3-4 times a day, they don't seek medical care, it means you have the whole family members actually sitting around to look after this individual. We discussed that being one of the effects of delayed in care. So we also, in this introduction, discussed the commonest causes which brings the high prevalences in epilepsy. So one of them was birth trauma. So I individually really agreed with this. So as somebody who's working in a low-income country, we experienced this in our labor ward. Advantageously, I'm one of the guys who works in labor ward. So I see, a lot of asphyxiated babies, those who eventually develop cerebral palsy, then they end up developing epilepsy. So we'll take back this and actually improve in those areas so that we prevent those preventable causes of epilepsy. Mm-hmm. And also treatment of febrile convulsions. So we should be able, as we've attained this knowledge from this training, we should be able to diagnose and treat early, as early as possible, this kind of conversion, so that our patients do not actually proceed to develop epilepsy. So we also see a lot of alcohol abuse in Malawi. I don't know. Yeah, so a lot of alcohol abuse in Malawi. So that's among the preventable causes of epilepsy. So I think people need education on the same. So we should provide more information on how epilepsy will affect themselves and eventually cause epilepsy. So I've really learned a lot from this training, Dawn.
Thank you, Kumbukani. That's a lot. And really, Samuel, you've got your work cut out where you need to liaise with.
And just to add, I remember just during the first week of the training, I remember seeing our Facebook group over flooded with messages. I could see that the nurses were so excited. I could see that they had learned a lot, and they were so excited, and were ready to implement. So I think I would just say to what Kumbukani is saying, that they've learned a lot, and it's been good.
Just to wrap up today's conversation, I'm just going to read a couple of feedback that we received that actually tallies with some of the things you've said today. Someone said this course was relevant because we have been working with people with epilepsy for quite some time, but we did not have enough knowledge and skills needed. But through this training, we have gained a lot of knowledge that will assist us in our daily practice. Another person said the sessions were informative and well put together. They brought on knowledge I didn't know about. For example, updated guidelines, and it was good to learn from practices from other countries and figure out whether it will be applied in our own country. Another feedback, it has exposed me to tremendous new discoveries in terms of assessment and management of epilepsy. I learned a lot about managing complications, medication choices, medical disabilities, and a whole lot more. Another feedback, the training was an eye-opener to me. This was my first training in epilepsy since I started working with people with epilepsy. I had little information on assessment and management of epilepsy, but now I've learned a lot. Last feedback here today is I actually learned a lot about epilepsy management. Also realized that I've been doing a lot not the right way. I'm so glad this took place. Thank you for making it available to us. I hope we use it to improve care of epilepsy in our countries. Thank you, Pretola. And really, as you can, those are just few feedback. There was quite a lot we received over the course of the 3 months training. I'm glad that we're achieving the aim of the training, because the aim is for clinicians like yourselves across that are working with people with epilepsies in low resource countries that have not had the training needed, can actually join in wherever you're at. Put your cup of water on the side, have your snack on the side, and learn from some of the best across the world. Learn from parents, learn from carers, learn from people with epilepsy themselves, learn different topics, learn new topics like the TSC, tuberous sclerosis complex week, which was amazing, by the way. I still can't get over that week. But also network with your peers across the world as well, and know that you're not alone. You're not alone. On the Telegram group, people were able to ask each other questions, and share questions, share learning, share ideas, which great networking opportunities. So I'm glad you found it useful. Thank you, Samuel, for coordinating it at your end. And it actually showed the amount of work required to actually achieve this, isn't it, Torie?
100%. And I love hearing some of those feedback quotes as well. It's really encouraging for Tolu and I actually to keep on going, to keep improving. I'm really looking forward to the next session that we're going to do. And I thank all of you guys here for giving that feedback. And also worth noting is, and this relates to what you were saying, Kumbukani, about the 70% of people who can have controlled seizures, which is great. But we can't forget the 30% who struggle not to be able to control their epilepsy. And a lot of those people tend to have a genetic epilepsy. Just to point out, this is I don't know if this was mentioned in the training, Tolu, but Dravet syndrome and CDKL5. Dravet is one of the most common, if there is such a thing, rare epilepsies. And we've got a 2-part series this month on the podcast and on the YouTube channel, Epilepsy Sparks Insights, about those rare epilepsies and the research going on. Now, I know that people in low resource countries often don't have access to the treatment. forgotten in countries where we're very lucky to have access. But as you were saying earlier, Eve, you know, there's like a you're working with people in positions of power, saying to them, by the way, dude, you know, we have loads of kids and adults, in fact, affected by these other rarer epilepsies. Well, darling, you need to give us funding so that we can actually provide treatment for these kids and indeed their families, because the epilepsy affects the whole family, right? So just to put it out there.
Sorry, you're the only human being I know that can call the Minister of Health dude or darling.
You're my fellow Homo sapien. We treat each other as equals.
Eve, any parting words? Do you have a final words you would like to say before we wrap up?
Yeah, just going back to the feedback, I think it's just great, you know, that someone is going to, you know, do their work differently just after this training, because in the past we've been having, you know, challenges in a way that people were assisted in a way that wasn't, you know, appropriate. So just hearing that someone is going to, you know, change the way they're going to assist, you know, persons with epilepsy, you know, that's very big and that's great. And thank you, Pretola.
We should just stand up. Let's work together, Sam, and make noise about this. Let's make noise, because this epilepsy we're treating as one of the NCDs. So let's make noise. If we make noise, we'll be there. Let's do it as our friends with HIV did. They had made noise and something improved. So if we join together to make noise from the implementation side up to the policy level, I think we can get there. And the message that I can cut across all sectors is everyone can have epilepsy. Anyone can have epilepsy. And it's preventable and it's manageable if we follow all appropriate steps. And make sure I don't increase the burden. The more pills we prescribe without assessing the patient, it always makes things difficult. So before we even prescribe, let's make sure we cut across or solve the problems below. So that's that. I'm for family-centered care and working on the transitioning things from adults to patients or across the board. Thank you.
Thank you, Eve, and really taking on board the part that you're working on the transition policy. We're happy to support you on that, and if need be, you know, I can get Kim Morley to support us on that as well. So happy to, you know, for you to contact us for us to support you around developing that. Torie, you want to say something on that?
Yes, also I recommend everybody, if you follow a person called Danielle Andrande. She's based in Canada, but she's done lots of talks on the transition. She focuses on the transition of patients from pediatric to adult care. And so she's very, very insightful on that. So I'll put a link in the comments below. So if you follow Danielle as well as Kim, I think you'll get great insight into how to make that more effective, more comfortable, etc., for the patient and the family, because we don't want anybody falling between the gaps.
Kumbukani, parting words from you?
So this side, I think, since we are advantaged since Evelyn is working with the ministry. So I know our pushing what we want to be that hard. We actually try to, you know, have more clinics in our facilities, epileptic clinics. I'm also coordinating an uncommunicable disease program at our facility, in which I know epilepsy is among the conditions. So we'll make sure that we incorporate epilepsy in the program, so that we're able to, you know, assist and screen these patients regularly. And in so doing, you know, we're going to improve the quality of life. So eventually, I would like to thank you, Tolu, Pretola, and Samuel for the training and this program of getting the feedback. Thank you.
Thank you all so much. Thank you for the feedback. Thank you for joining us today. Thank you for those who are watching at home. And it's great to hear and to see that there will be an improvement in epilepsy care in Malawi. And that in itself makes us so happy. That in itself just, validates all that we're doing. And the EAMC, yes, there will be another EAMC, Epilepsy Assessment Management course next year. And there's a waiting list already. So if anyone wants to sign up and, go on the waiting list for next year, go ahead. But thank you so much, Samuel. Thank you, Kumbukani. Thank you, Eve. Thank you, Torie. And do have a lovely afternoon.